So really, it is quite exciting to present this work. I think hopefully you will share my enthusiasm that what we're really doing here is a community-led effort to think about how we can tackle some of the broadest and biggest challenges within the child health community that I actually think is going to have broader implications across the rare diseases community as well. And so my name is Nickhill Bhakta. I'm a pediatric oncologist, as was shared. And I think you would be fair to ask the question, why is somebody who's interested in disease burden estimation as well as health economics giving a talk on novel diagnostics and leading a unit in that? And the reality of that is because the challenge at a global level is really one of logistics, of implementation, and of cost. And how can we bring this together? And so the work I'm going to be presenting is actually not just me. Obviously, I work with people like Jeremy Wang, who's a computational biologist at the University of North Carolina in their Department of Pathology, Thomas Alexander, who does translational medicine work also in North Carolina, and then a whole host of collaborators who are the real stars of this work. So Javeria Ijaz, who I think is here, Mayur Patihar, Rubina, and many other collaborators. And I say all of that to start because, I think it's become a little bit of a meme within the community about this concept of democratizing diagnostics. And everyone will talk about it, but are we really doing it? And I do hope that over the course of this presentation, you will see that this actually does represent, in terms of methods, in terms of intent, how we can work. So not only I want you to pay attention to the assay development, the results, the effectiveness, but also how we went about creating this work and how we moved so quickly. That's, I think, the secret sauce to what we've been doing. So I have no major conflicts of interest. Parts of the study have been supported through the support of Oxford Nanopore to our partners, not to St. Jude. We also did get funding through a grant award mechanism from Amazon Web Services, and we have an NIH R01 that has supported some of the cloud transfer as well as sequencing hardware in a couple of our sites. So as a pediatric oncologist who is interested in global health, it's often the challenge to ask, well, this is a really complex problem. Where do we start? And the way I think about this, and this is to ground all of us in kind of what is happening at the global level, because you can think about, both those of you that are not familiar with the space, it can be challenging to say like, well, if you get the diagnosis, what's the point if we can't get the treatment? And so I often think about this as the child journey of my patients. The child has to get identified and referred into a hospital. And in many parts of the world, that doesn't happen. Children are either misidentified, they're called tuberculosis or malaria, and they end up passing before they can even get to a hospital and get a proper diagnosis. Once they get there, they obviously have to get a diagnosis, but then the diagnosis isn't enough. We actually have to have access to the treatments. And those treatments have to be adapted to the resources of the center that they're at, meaning that many centers won't have all of the same bevy of things that we have at St. Jude. But that doesn't mean that we can't cure those children. And so understanding and making sure that they not only have access to those to the treatments in terms of the management plans, but also the medications and technologies that are needed in order to make effective those cures. And then finally, we need to make sure it's occurring both in a supportive care environment where we can manage things like toxicities and other comorbidities, and do that in a way that we can measure it and make sure that it's all working. And what's really exciting is that in the last 10 years, childhood cancer has gone from this obscure disease that has not been looked at the global level to now being a signature initiative within the World Health Organization through the Global Initiative through Childhood Cancer, which is in partnership with St. Jude. From there, we've developed packages like the Cure-All package, which is a technical advice tool for governments as well as facilities in order to understand how to implement childhood cancer services to support that ecosystem. We've developed ARIA Guide in partnership with SIOP and other professional societies, so St. Jude Global, SIOP, IPSO, and PROS, and others in our group, as well as patient and family organizations, to really think about how we can develop the best care for any child wherever they are, not necessarily having to rely only on those that are on high-income countries and are not feasible in resource-limited settings. Through a $200 million effort over 5 years from St. Jude, we are now delivering free cancer medications to 7 countries with the goal to scale up to hopefully 30 to 50 countries over the next few years, impacting 120,000 children. This is in partnership with also the WHO as well as UNICEF. So this is truly the first of its kind in the non-communicable disease space, thinking about how we can create both a global fund and health system strengthening tool to ensure that access is available for treatment. And then we have a whole bevy. I'll give you an example of EVA, but we have a bevy of supportive care interventions and quality improvement interventions run through St. Jude Global and our network of over 400 hospitals in 100 different countries, where we have structured MOUs and have these learning collaboratives where we all work together to improve care for children. And then, of course, we have two hospital-based cancer registries, now over 40,000 patients and growing, which allow us to monitor and track. So all of these are out there. So the ecosystem for childhood cancer is growing. But there's been a massive gap. In these last 10 years, we have seen almost no progress from either the UN agency side, from our partners, and from St. Jude. And how do we address the broad global diagnostics gap? And so why is this important? For those of you that are not clinical, childhood cancers, and I use the cancers here because most time people say childhood cancer, but childhood cancers are complex. There's multiple different types of cancers. And I'll give you the example here of leukemias. It You start with a patient coming in, and we can look at their age, we can look at their race or ethnicity. And what we do then is we have some basic information that we can look at. We often ask our pathologists to look at under the microscope at the morphology, and that'll give us an inkling. Is this leukemia, yes or no? But that's not enough information to make a decision. We still need significantly more information, ranging from phenotypic data to macrogenetic data, as well as molecular data. And each of these different inputs provide us different pieces of information, with each piece of information being critical to risk stratify and then identify what is the best treatment for a child. And if we don't have this, we sometimes will treat the wrong disease, taking potentially a 90+% chance of survival down to 0%. Also, we may end up overtreating children and giving them extra or more chemotherapy, which comes with increased toxicity, increased death because of because chemotherapy is, frankly, as I tell my patients, stupid and ultimately kills patients if we don't manage it well with toxicities, and cost. And so the reason this is a challenge, the reason why we have these is that each of these tests are necessary, but they also progressively get more expensive. And so what is that gap? What does access look like? So as I said, St. Jude has partnerships with over 400 hospitals around the world, and we've done deep dives with over 300 of them, where we have these 600 question surveys of assessments and then quality improvement planning tools that we work with them. And in the pathology consultant, this is just for leukemia. You can see here the different types of testing that you would want through our profile assessment. And I organized it by low middle income, upper middle income, and high income country based on the the World Bank classification. And if you look at that, you have timely diagnosis of morphology, flow cytometry, cytogenetics. And in lower middle income countries that have participated in this and are part of our St. Jude Global Network, you can see that morphology is generally available within 2 days, though in the low income countries, that's not necessarily true. But any of the genomic tests are basically non-existent in low income and are very limited in lower middle income countries. And what does that mean? That translates into significant challenges. So you can see that here in this figure, this was modeling work that we did a few years ago, highlighting that up to about 50% of children who develop cancer, so we estimate there's 400,000 children that develop cancer, about 50% of those will never get diagnosed in the first place. They will die either because of a misdiagnosis, TB, malaria, whatever, or they'll get diagnosed because they were missed, meaning that they never got to a facility in the first place to be diagnosed. And this has severe implications. This is another study that we did a few years ago because we didn't know what global survival looks like. And so using, again, modeling data as well as available population-based cancer registry data, we estimated that global survival for those that are diagnosed with cancer is about 30%. But when we include those that are missing, those undiagnosed patients, global survival is about 20%. So meaning that 20% of children who develop cancer around the world will survive their disease. This is one of the largest health-related disparities in all of global health. We brag in the United States and in Europe that childhood cancer is a marvel of modern success because we can cure almost 85% of children in the United States, in Europe, in Canada, in Australia, in Japan. But hidden behind that 85% statistic is the reality that only 20% of children will survive. And that 85-20 split is a massive issue. And driving it, there's one of the challenges, of course, there's multi-factors, but driving it is that across all tumor types, I gave you the example of leukemias, but all tumor types, 75% of children who develop cancer will get either an incomplete, wrong, or just get no diagnosis at all. That is a staggering gap. And that is if we want to make progress towards what is our goal, that by 2030 we reach 60% survival for children, taking that from 20 to 30% up to 60, we have to address the diagnosis component as well. And so I showed you all of the tests that are needed, and that obviously comes with supply chain challenges and cost. But another major issue is just the workforce. This is a figure from the Lancet Oncology Commission on diagnostics, and you can see here there are just limited pathologists, especially in Africa and in East Asia. In fact, the estimate was that it would take 100 years to train enough pathologists in sub-Saharan Africa in order to meet the demands of today, let alone the demands of tomorrow. And so I say that because there's multiple factors that we can't just think that we need an assay and we need to create something, publish a paper, put it on GitHub, and assume we're going to solve the problem. We need to think about the supply chains. We need to think about the cost and the cost acceptability. We need to think about the workforce and the training needs. We need to think about the implementation standards. We need to think about how we can have the shipment and ensure that we have quality indicators embedded throughout. And so this takes us to our journey. I think Ellie's already talked to you about adaptive sampling and whole genome sequencing. We actually started looking at this about 6 years ago with RNA-seq. At the time, and still even today, in the United States, RNA sequencing is kind of the next frontier that people are pushing for leukemia diagnostics. But we really didn't feel as though the RNA-seq was necessarily going in the right direction for us. We utilized shallow-based RNA-seq, and we've published on this, and I can point you to those publications if you're interested. But at the end of the day, it's still an association. And so 95% is just not good enough. It gets us a lot better, but it's still not good enough. And so one of the things that we started to play around with about 3 years ago, really a credit to Jeremy Wang and Thomas Alexander for their work and pioneering in this space, was testing adaptive sampling whole genome sequencing. And as Ellie noted, this is a computational mechanism that allows us for real-time on-sequencer DNA enrichment. And this, for us, was the holy grail. Because of number one, it's PCR free. As we were trying to figure out how to do this, we wanted to have an agnostic approach, something where whatever tools that we use, whatever supply chain that we had, that it wouldn't be specific. Because the reality is, in many centers, most centers around the world diagnose between 150 to 200 new diagnoses of childhood cancers, maybe 30 to 70 leukemias per year. And so if you're trying to manage a supply chain where you're ordering primers for 30 to 70 patients per year, whereas that same lab is trying to manage HIV or TB or others when they're ordering thousands of reagents, the reality is this is always going to have a stock out. Patients are going to get missed, and there's going to be issues with trying to maintain stability. So we wanted to have a tool and a standard which would allow us to integrate not just only have vertical solutions, but horizontally across the health system. And that's what's so cool about this, is that it's PCR free. It was a simple DNA prep. It doesn't require anything special in terms of what any molecular lab is otherwise comfortable doing. And we know that because of HIV, because of COVID-19, because of all of the viral diseases, many of the labs around the world are getting more and more comfortable with molecular DNA prep. It also needed, obviously, rapid, cost-effective. It needed to be easy to update so that we could continue to improve it as we made improvements. And then we loved this idea of the whole genome backbone because that gave us an equity approach. Some centers may take a simplistic, others may take it a deeper, and I'll talk about that more in a moment. And so we moved quickly, and last year published showing that using this adaptive method with the whole genome sequencing at a low level, we could integrate in digital karyotyping. We could also do CNV, SNV, fusion identification, ITDs, UTDs, all of those. And there's been several papers now published on methylation classification as well. And so last year, we had this publication. It showed that adaptive sampling was feasible in this context. And we were at a decision node. We could either continue to tinker with it, because this was only about 57 samples that we played around with at this time, or we could go big. And we could say, look, we feel confident with these 57 that this works. It's DNA. We're looking at it. It's not like an association. It's not like we have to have thousands of samples in order to create a reference library. It's there or it's not. And a lot of this is about a lot of the hard work is coming from Jeremy's team, where he's having to add in all of the things us clinicians want to make sure that it's automated in the collection and the data analysis process. But even when it's not in there, it's still in the raw data. So somebody could go in and look for whatever you want. It's whole genome sequencing. It's all there for the taking. And so we, instead of thinking about how to just continue to tinker about with this for the next 3 to 5 years, put it on GitHub and assume that someone else is going to solve the problem of implementation, we decided to go in a different direction. And while there are many reasons, one of the biggest ones was actually a patient that my colleague Thomas had. And I remember in real time hearing this story, and it basically just was like, this is the future. This is what we need to do. So at UNC, genomic sequencing is not standard of care. At St. Jude, every patient who walks in our doors gets their whole germline and gets their somatic DNA sequenced both. But at UNC, it's not part of their standard of care. And so, and even then, it takes us about 2 to 3 weeks to get results from our whole genome sequencing results. So he had a patient that came in, there was a decision node. Was it leukemia? Was it a solid tumor? Their pathologists were going back and forth. And basically, one afternoon, Thomas, while on service, he went, put in an emergency IRB because we had pretty good indication that this adaptive sampling was going to work, got approval, got the patient's parents to agree, and essentially did adaptive sequencing on this unknown diagnosis child who was in significant pain. Took him 2 days on a PCA to get the pain under control. And it would have taken another 2 weeks before they could have started therapy because they didn't know what this was to get the sequencing results back. And within 2 days of him coming on service and then submitting the IRB and then sending it on Tuesday to the lab for sequencing, by Wednesday afternoon, they identified that this was a GLIS2 fusion, which is a rare type of AML, which is actually refractory to standard of care chemotherapy. So together with the patients, they actually they did a personalized approach and did a targeted immunotherapy approach and got this patient into remission. And within a couple of days, the patient was pain-free and doing well in the wards. This is a case example, but it shows the power and the opportunity within this. And the reasons are because we can, and we haven't even fully optimized this, I'm going to be completely honest, but we can do these workflows where within 24 hours on a single plex or within 72 hours multiplexing 3 samples, we can get a result that can actually be faster than most of the conventional pathology and much, much faster by orders of magnitude than any of the NGS approaches that we have currently. But also the cool thing about this approach is that it gives us an opportunity to de-implement and also give us both the ability to leapfrog the current standards of care that are otherwise lacking in many settings. And here you can see on the left-hand side, all of those tests that I showed you in the blue are the types of information that we're getting from each of those tests. You can see that each test is giving us different pieces, and those different pieces are essential for us to then put all of this together. This is why I went to med school and residency and fellowship, is because I can put all these things together and give us that sense of what is the risk for a patient and then map that to the right therapy. But that requires a bunch of different tests, a bunch of different time, a bunch of different costs, and a bunch of different assays. And we've been trying for 45 years, 50 years to scale these in resource limited settings. Heck, even in places like North Carolina, where we can't do transcriptomics as standard of care. So this is not only a global problem, this is a US problem. There's 200 plus sites in our children's oncology group, and only 20 of them probably do next generation sequencing as standard of care. So how do we make sure that even the children here in the US get accurate, quality, comprehensive diagnostics? And that was really what got us excited about adaptive sampling, is that on one single assay, we could integrate all of these data, and using a couple of different pipelines. But NASPAR is our DNA alterations collar. That's an automated collar that we've developed through Jeremy Wang's lab, and then the methylation collars that many of them are using, and I'm sure you have seen in the literature. So what did we do? Just taking that theory to action. So the first is, as I said, we're democratizing this. We actually got a coalition of the willing. We have over 400 hospitals in our network. We had 12 of them that were kind of coming to us already saying, we really want to work in the NGS space, but we don't really know how. There were other solutions that were just going to be too expensive for them, other things that we could do. So we got 12 hospitals and teams together. And the first thing we did is we came up with our adaptive enrichment list. We said, let's come up with this together. It's not going to be St. Jude. It's not going to be UNC. Let's make sure that everybody buys in and then have some consensus and standardization. And we had a whole methodology to do that. The other thing that we did was we said, okay, each of you live in your own regulatory environments. Rather than having each hospital come up with an LDT process or a laboratory developed test in order to make this a clinical test, and I'll get to that in a second, we said, let's all come up with that concept of what an LDT would look like together, and then account for CAP and CLIA and ISO and all of the local standards. And if we know that, we can actually use the same protocol and then just have real world adaptations built in. And the reality is that if we do that together, we don't have that kind of first step, which is always a big challenge, which is having to write your own protocol. Just borrow this and make some small modifications and then go forward. And then we also developed infrastructure in order to help support analytic reports and support the implementation as well. And so what we did then was we looked at the centers that were ready to go on as soon as we got those pieces, and there were 4 centers that were like, let's just do this. And so instead of doing assay development, we used an implementation science-based approach, multi-center, which is self-evident, 4 centers around the world, something called a type 2 hybrid validation study. So what does that mean? If those of that are not familiar, there's type 1, type 2, type 3. What these hybrid studies do is that they allow us to study both effectiveness of an intervention and implementation of an intervention as co-equal objectives in the study. And so we utilized that design because the goal of the study was to do a laboratory developed test validation with the intent that each team in each hospital, if successful, would have an assay that they could then move forward to clinical return of results. Not messing around with more assay development, GitHub, assay development, publication, GitHub, whatever. Let's get this into the hands of the clinical labs and ultimately make sure that children are benefiting from our research now, not tomorrow, not next week, but now. And so we started with the development of 41 samples from North Carolina, and then, added to those 47 samples in North Carolina in the research lab, and then they started doing it in their clinical lab as part of their validation. And then we continue to kind of tweak our pipelines in collaboration with the colleagues from Tata Medical Center in Kolkata with Mayur, Bhaskar Saha, and others. And they ran 112 samples. We also, in parallel, ran short read whole transcriptomics to look at orthogonal to ensure that we had our conventional testing that they did. We had the Illumina, and then we had the adaptive sampling, and that allowed us to have those orthogonal approaches to make sure that we were capturing everything, and also to continue to make pipeline refinements as we moved into that version 2.0. Then we shut down development, and we called it version 2 of our pipeline from what was published previously last year. And we worked together with folks at Princess Maxima. And Princess Maxima is like St. Jude. They have whole transcriptomics, whole genome sequencing, whole exome on every sample that comes in. So for 129 samples, they had their ground truth data, and we also had the adaptive sampling, which allowed us to have a kind of apples to apples comparison of ground truth to make sure that this was working from a quality standpoint. And then our colleagues led by Javeria at Indus had the ability to run adaptive sampling. And for them, they were able to look at what the real world impact was. We looked at 80 patients who came through their door and sequentially sequenced those 80 patients on adaptive sampling and compared that to the value add off of the limited conventional pathology that they had locally. And then we looked at implementation outcomes of feasibility, fidelity, appropriateness, and cost. And I'll briefly walk through those in a minute. So from an effectiveness standpoint, what have we done? So I'm going to give you some unpublished results. There were the preprints available online. And you can see here, first of all, those of you that are not familiar with leukemias, so we oftentimes bin leukemias into different subcategories, and then we look at different classification categories, which allow them to be risk stratified. And so you can see in green here, low risk subcategories that are based on genomics. The red are poor, and then you have intermediate as well. These require genomic testing. Those in blue require more expression-based testing, and we'll talk about that in a minute when I get into the methylation work. And these risk assignments are based on the NCCN guidelines, so in case you're wondering where they came from. And so I'll show you in a minute a couple of different of these confusion matrices. For those, again, not familiar, you see on the kind of that x-axis approach A comparing to an approach B. For the next few slides, you'll see approach A is our adaptive, approach B is going to be the comparator. And in that, you'll be able to see the correlation along the diagonal, which indicates agreement. And the leading differences will represent, in that, especially the B other group, will represent clarity from one technique to the other. So this is for the 129 samples from Princess Maxima against their Illumina whole-based whole genome, whole exome, whole transcriptome sequencing. And you can see that out of the 128 samples that we had in this, there were 126 samples that were correlated using our automated caller. And then there were two that were not called on the automated caller. Now, this is really important. So out of 126, we submitted the results into our automated caller, and with 15 minutes after the sequencing was done, we had answers, and they correlated with the short read. For two, we didn't find the answers off of the automated call, but we did get it off the short read. I'll walk you through those two in a minute, but just to give the ghost up, we ran methylation against them. We had suggestion that methylation was put them into the categories that were correctly identified on whole genome, whole exome, whole transcriptome. And then when we went into the adaptive FASTQ file, we found the alterations. They just were not included in our automated caller because our automated caller knows what to look for. One was a rare, less than 1% of NPM1 mutations, and the other one was a CVP alpha that was in the non-zip region, which is also rare. So these rare subtypes can be found, and orthogonal testing can help us to do targeted reviews, which also save a bunch of time. And so there's a lot of opportunities here around turnaround time, cost savings, and simplicity. And so then we looked across the whole cohort, 457 samples, and you can see that those two DNA alterations that I noted were the only two that were not correlating, but they were found after the targeted review. And then we saw a whole bevy of across our cohort added value because we were able to identify these B others from just the automated adaptive sampling. And so again, for high-income countries, within 24 hours, we can give you a comprehensive genomics result that would often take between 1 to 3 weeks, even in the most sophisticated labs to get, which as a clinician is amazing. As a pediatric oncologist, it gets me giddy. And of course, from the labs, it gives that technical and computational simplicity. But for low and middle income countries, it gives us that increased diagnostic classification, and I'll show you in a moment that potential for cost savings. But the real cool component here is that multiple omics opportunity that DNA methylation affords us. And so there's been multiple publications now with rapid classification using acute leukemias methylation. So I'm not going to go through the methodologies there, but we can integrate all of this into a simplified compute so that in less than 30 minutes, we have all of these pieces integrated with a simplified compute into an automated editable report that can be given to the pathologists. And in that, like I said, we can integrate the methylation. So here are these B others that I showed that were still remaining that the DNA alterations did not find. And the vast majority of those are actually explained by these subgroups that are called PAX5 and pH-like that cannot be defined based on DNA alterations, but are defined based off of gene expression patterns right now based on whole transcriptomics. And first and foremost, when we compared our DNA methylation to whole transcriptome, we see that there's a very good correlation between the two, that methylation is a good surrogate for expression patterns. But what's interesting is we can also see the driving things like in PAX5 alt, we can see PAX5 alterations that are likely driving that. Similar with other like lesions, like for example, a RUNX1 like lesion, where ETB6 runs one like, we can actually see the ETB6 rearrangement in the DNA alterations. And for example, for ZNF384 like lesions, we can see a ZNF362 known lesion that actually acts similar to ZNF384 and is contributing to that. So we have these intra-genomic orthogonal correlations to the methylation data, which is based on more of an expression-based approach. Of course, there are still going to be some B others, and that's true with right now our whole transcriptome, whole exome, whole genome on short read. We still can't bin 100% of leukemias and BALLs and AMLs. There's always going to be an other category, and even that still goes on today as we make progress. And then, there still are some opportunities to improve where there were correlation issues with the methylation and the gene expression pattern. But the cool thing again is this was all on a single assay. It wasn't whole genome, whole exome, whole transcriptome. It was one adaptive sampling assay. And that integration of multi-omics, it truly increased the yield. So over the entire cohort of 457 patients, we increased the classification by 26% across all 4 centers. At a place like Princess Maxima, where they do whole transcriptome, whole exome, et cetera, we had greater than 99% match with the Illumina. The only non-correlation was a case that on whole transcriptomics, first of all, the DNA alterations matched. On whole transcriptomics, they called a low probability pH-like, but we did not call that alpha methylation. However, we saw the DNA alteration of CRLF2, and that would not have changed the clinical management of that patient. And so, even though it was not called the methylation and the transcriptomics, the DNA alterations did match, even on that one sample that we had, where we would say that there was a discordance between the short read and long read. And then for in this hospital, where we had very limited pathology, next generation sequencing using adaptive sampling increased the diagnostic yield of those 80 patients that were sequentially done from 28% to 84%. And that's a massive improvement. As I mentioned, it costs 3 to 5 times more to treat a high risk patient compared to a low risk patient. And 50% of the low risk patients were actually being up stratified to high risk. And then a paper that's coming forward from the Pakistani group, one of the biggest challenges they had was in their treatment for ALL, their upfront toxicity due to infections, due to giving intensive chemotherapy. By giving lower risk therapy, that actually potentially reduces the morbidity and the mortality risk of patients in their setting and could potentially improve survival, not just only toxic morbidity. And this is the real world implications of these work. And so based on that, UNC is planning a July 1st rollout as a standard of care for their acute leukemias. But I'm so excited and proud of Jabari and their team because they were able to take their data, show it to their hospital leadership, and convince them to make the standard of care for all new BALLs in their hospital based on the results that they got, as well as the costing work that I'll highlight in a moment. Maxima is doing more of an incremental implementation because they already have such a robust short read, but they see value add to this. So over time, we suspect that that will continue to expand in terms of how it's utilized. And Team Sequel Cut is currently working through the regulatory requirements and finalizing a kind of long-term reimbursement model. And so finally, just to highlight what are the costs? I know that this is something that is going to be at the top of everybody's mind. So it obviously depends on how much you can multiplex or singleplex. And so this is where the equity question comes in. In the US, next generation sequencing reimbursements are already thousands, if not tens of thousands of dollars. So this is the cost for reagents and flow cells. All right. This doesn't include like a lot of the lab costs, et cetera. But we actually think that this allows us to de-implement things like karyotype and FISH and PCR. So that time that's spent in the lab for personnel, those are sunken costs that actually potentially through de-implementation can be saved. So really it's about the reagents and the flow cells to some extent. And so single plexing, you can see that it's about a little bit over $900, with the majority of that cost being in blue, which represents the flow cells. But then when we get to three-plexing, which is what we've been doing in Pakistan and in India, we actually see that price fall below a $400 threshold. And that's kind of like our threshold, which gave us a signal. We need to be below that still. But if we got to a 400, we felt like, okay, we have somewhere where we're going with this, that we can continue to optimize and we can continue to get volume in order to continue to bring prices down. And so we feel like we've hit that at that three pass, but it still is yellow because we have seen that sometimes the flow cells as they come in, that we do have some flow cells that have not performed as optimally, and as a result we have to resequence as a result. And I'll show you how that matters in a minute. But we think that also by integrating in methylation and with equity-based approaches, some sites may feel comfortable with calling a final call based on methylation. And so that would allow us to get 4 or 5, maybe even 6 samples off of a flow cell by stopping sequencing early for some samples. That would also drive costs down even below 200, between $250 to $300. And just to highlight, we do see variations globally. We know that there's export-import taxes, customs taxes, and then just channel partner differences. And so there is variation that we have to be at when we think about how the costs mass out. And I said that some samples have to be resequenced. We saw about a 10% resequencing rate. So in that yellow group, we had about 10% of samples needed to be that. But even with 10% resequencing, we're still below that $400 threshold. So that was really reassuring to us that based on the data that we're seeing, based on what's happening in real world clinical labs, we're still able to maintain below that threshold. There are some limitations. We need to see a blast percentage greater than 40%, generally or 50%. And that's particularly for the copy number analysis. On the fusion calls, we can go down to 10%. And that is, that for in almost all of our patients, they come in with high blast percentages of 80 to 90%. So that's a challenge, especially if you get into like MDS, et cetera. But for acute leukemias in children, that's not as big of an issue. And of course, there are some trade-offs as we think about variable allele frequency, et cetera. But we're, again, at a clinical level, we're not really seeing that as much. Um, Our one point is that our approach is targeted analytically. So as you saw with that NPM1 and that CBP alpha example, there is still significant headroom to continue to improve our analytic automated caller. And so, like I said, if in 15 minutes we get all of these calls, there will also be, we will continue and we have a roadmap to add on additional calls into our automation results. So that way it saves on any having to have the bioinformaticists or having pathologists spend time going through the raw FASTQ files. So as we take a step back, when we started this journey, we had some key questions. First, will it make a difference? And I think you saw the case of the one patient in North Carolina who not only was diagnosed, had their pain resolved much faster. That is a 2-year-old that is having pain resolved in so much more time because of having this access to this test. That in and of itself should hopefully explain to you why, as a clinician, and why others of us feel like this is obvious, not even a question. But then for the, you saw the data from Pakistan as well, where it increases the yield of those low risk patients, and then reduces the chemotoxicity, hopefully reduces deaths, and most importantly as well, does that in a way that can potentially reduce costs and subsidize the cost of the actual assay itself. Going to costs, we feel like it is cost accessible, but there's still more work to be done to optimize that. Does it work? You've seen the data from Maxima, the correlation with short read, which we used as our orthogonal ground truth, that we feel like this, we've got enough data from over 450 samples to say yes. And can it be implemented? Yes. We've done this in settings from limited resource, limited settings where they only have access to karyotype and a couple of fish, all the way to settings where we have the most state-of-the-art diagnostics. And I it has all come at a time where just 2 weeks ago, for those of you that are familiar, the WHO had the World Health Assembly 2 weeks ago in Geneva, and they passed the resolution calling for precision medicine. And in there, this was the member states, this is all the countries in the world, that the member states actually in this resolution specifically urged all of their groups to establish or maintain evidence-based mechanisms for the assessment of prioritization of precision technologies to evaluate their clinical effectiveness, cost-effectiveness, safety, and quality. So this came after we finished the study. Actually, we've been submitting the preprint out. The WHO is now asking for, and member states are asking the WHO for, advice and guidance how to do what we are doing. So we need more of these studies. We need to continue to push the envelope. So what's next for us? We've done these 457 samples. We're expanding to continue, and we're continuing to expand. We're not just sitting around. There's already now multiple centers that are starting to sequence and are working with us. And I would say if this talk has gotten you interested, our email is there. We are happy to collaborate. This is an open source collaborative and a coalition of the willing. We want to get this out there as fast as possible to benefit as many children as possible. End the story, period. And we will work with you to do that if you share those similar goals with us. And I just want to highlight again, this has been a village, a team effort. I have to also acknowledge our collaborators, Bas and Leonard from Princess Maxima, who are critical collaborators in this effort. I've already talked about Thomas and our colleagues at and Jeremy and our colleagues at Tata and Indus as well, who have been essential to moving all of this efforts forward. So with that, thank you so much, and I am available for questions.